Okay, so we're very fortunate to have our keynote speaker here, Dr. Barish, who gave the best lecture I think that I've heard in many, many years about safety. It's such an important topic, particularly in the cardiac surgical patients. So have you attended this meeting in the past?
This is the first time. I'm delighted to be here, and I've been very impressed with the level of scholarship, the attentiveness, and the engagement around we can do much better.
Yeah, and as you talked about, the whole team includes the patient, but the one thing that we can do here is bring the rest of the medical team together in a very unique environment, and it's not just about one profession or the other.
Well, fundamentally, all safety is predicated on the microsystem, and the microsystem is predicated on a group of individuals centered around the patient, and they include nurses, pharmacists, allied health, and physicians. And that model replicates the real performance model. So unless and until we accept that, right, we'll have episodic care, but we won't get reliable care.
Yeah, one of the things that have come out from the patient safety perspective has been the concept of chasing zero.
Yes.
And I've really liked that in the area of zero errors. I just wonder, I've thought about, because I'm giving a lecture tomorrow morning on optimal pain management. Yes. I'd like to come up, I'm going to put this together on a slide. It says, chasing zero opioid-related adverse drug events. Do you think that's even possible?
No. I think that we need to strive towards chasing zero harm, not zero errors, first of all. I think humans make errors because they're humans.
That's right.
And the question is, can we design systems to capture the errors before they propagate to harm, number one. Right. Number two, opiates are some of the most dangerous drugs on earth. They're also some of the most important drugs on earth.
Absolutely.
And so the question is the trade-off of the potency of the drug versus the toxicity of the drug. And in general, I think we do not teach about the dangers of opiates properly. We're very cavalier about who can prescribe them.
Yes.
We're very cavalier about who can manage them. And we don't really appreciate that their effect, acute on chronic, can be very different. And so the combination of all the above means that the risk ratio of opioids is very, very high. And so we need, I think, special training for opioids. We need to decide which opioids, like Dilaudid, need to leave because they're too dangerous. We need to decide which opioids are optimal, short-acting, clear antagonists, clear ability to manage and not abuse. I mean, so it's a very, very tricky space, and I don't think we're having enough of a dialogue about the balance between benefits and hazards around opioids.
And, we've used these drugs for hundreds of years, tincture of opium from the poppy seeds.
Yep.
Yet, just last year, the Joint Commission came out with a Sentinel report on optimal opioid use.
Yes.
There was nothing new in there, but it was them saying, you folks aren't doing it right.
Well, it's the number one most offensive drug in adverse events.
Absolutely.
And because it's so pervasive, it's going to continue to remain number one because it's used so often, or I should say misused so often. And so my sense is that we need to target opioid use much differently than we have. We need to separate it, we need to better understand it, and we need to help clinicians understand the risk-benefits, which is much more than just a typical cavalier approach, but really understanding that it contributes to a huge amount of morbidity, a huge amount of toxicity, and a huge amount of deaths.
It really does, and it almost has the Rodney Dangerfield. I get no respect.
It's true.
It really does.
It's true.
More than an antibiotic or an anticoagulant.
Absolutely. And again, because everybody uses it almost, because it's so easy to prescribe it, it opens it up to so difficult to oversee. And I'm not a huge believer in external regulation alone. I'd like to see self-regulation plus external regulation done in a way that enables clinicians to do their job, but also make sure that certain drugs should not be done or used. For another example would be propofol.
Right.
Powerful drug, a dangerous drug,
Absolutely.
but an amazing drug. We don't really understand it exactly. We know it can cause sepsis. We know it can cause problems. We know there's a shortage in the world. But most importantly, we know that only certain people should use it because it's unpredictable. And opiates are no different. A little bit of the orange stuff, a little benzos, a little narcotics, and before you know it, you have a little monster on your hands, and even master users get surprised by people who don't seem to be opiate sensitive, and they just keel over in a small amount. So.
Now, do you think the recent development of the HCAP scores that have financial implications, and two questions in there relate to pain management.
Yes.
Do you think that will have an impact on improving pain management?
Well, I think first of all, it'll raise the awareness that we're not doing as well as we can, and I think we can do better. So I think pain, as people talk about this fifth or sixth vital sign, I think that's very important. But part of that is that we don't train physicians to manage pain well, and so we have a combination of we don't train pain management well, and we don't train people how to use narcotics well. The combination is having the wrong drugs not used well for a lot of patients. This is a recipe for complications, for longer hospital stays, falling out of bed, et cetera, et cetera. So these are serious issues.
Well, fortunately, a lot of these are being discussed at the conference this year. Dr. Barris, it's a pleasure meeting you. Thank you for your time and your wonderful presentation.
It's a pleasure. Thank you so much for having me.